Well, thanks for having me, Williams. So as William said, my name is Doral Fredericks. I am the Vice President of Medical Affairs and Global Communications for Bausch & Lomb. Just to give you a quick background as to why I am actually okay to talk about this since I'm not in sales or managed markets anymore. I did my PharmD and my MBA at USC, and then did a residency at Kaiser Permanente in Harbor City, which is sort of the Port of LA area. Was there, got hired on and was there for about a year and decided that industry was really where I wanted to go. So I started out as an MSL with Astra Pharmaceuticals, which became AstraZeneca. Was there for about 2.5 years and then moved over to Novartis for about 9. And at Novartis, I did a variety of different things as a medical science liaison, a director of the MSL group, as the director of managed markets, hence why I'm talking about this. And then finally left off as the regional medical head for the western part of the states, and then moved over to ISTA Pharmaceuticals as the vice president of medical. ISTA was a small ophthalmic company based in Irvine, which was recently acquired by Bausch & Lomb. And so I was asked to stay on as the VP of Medical and Global Communications with B&L. So I've been with them since about last June. All right. So I've done a variety of different things in industry and glad to be here talking to you today. All right. So talking about kind of what I want you guys to achieve today, fairly easy. This will be a casual lecture, so please ask questions as we go along if you have them, because the more I know this stuff already, so it's better for you to ask me the things that you're interested in and I can give my insights on things. So what I'd really like you to walk away from this lecture is to understand managed markets and how it's really working in the new healthcare landscape, because with the Affordable Care Act, things are changing very quickly. Okay, I'd also like to give you an idea about the things that you have to think about with regard to putting together a managed care strategy and a sales strategy. And those are the two things. So if you get that, I'm good. So I'm going to break this down kind of into 3 ways. The first one being sort of an overview of managed markets, the healthcare landscape, and what we're really thinking about when we're talking about managed care right now. Okay? We'll then go into what makes up a good managed care strategy and how that relates to a sales strategy. Now, have you guys had your marketing lecture yet? The pieces of like what goes into marketing for a commercialization product? I'll take that as a no. All right. I'll be touching a little bit upon that. Normally that lecture comes first, but I know it's always changing based on when the lectures are available. So if you have any questions about how that fits in, let me know. But managed markets, sales, and marketing all really fit very closely together, so it's important to understand and think about aspects of each of them. Okay. When we're thinking about, the first thing is who are managed markets customers. There's 2 main things to really think about. First one, they are entities that play a key role into how drugs are delivered to patients and the rates that they're going to be paying for it. All right. They do exert a lot of influence now, especially more than ever, over the choices of drugs that physicians and pharmacists can get to their patients. And what's interesting is they can be public or private. So the public is really the government paying, and the government is becoming a larger and larger piece of this whole puzzle. 15 years ago, Medicare Part D didn't exist. Medicaid was relatively small, and it was the managed care landscape was dominated by the Cignas and the Aetnas and the Uniteds. That power is actually shifting, and I'll show you how that impacts pharmaceutical industry in just a minute, okay? So when we talk about sort of the largest managed care channels, what are we thinking about? So the first one are commercial plans, and these are private entities that are either managed care organizations or pharmacy benefit managers, okay? What's interesting and something to keep in mind about these is managed care organizations probably aren't quite as price sensitive as you might think. It depends. It really depends on if they're an integrated force or if they're carved out. And what I mean by that is companies that sort of do disease state management are much more conscious about the overall cost of care as opposed to just the cost of medications. So even though a medication may be a little bit more expensive, they may be willing to put it on formulary because overall it may decrease utilization, all right? As opposed to like the pharmacy benefit managers or carve-outs in the managed care organizations that are interested really only in price. So a couple of things to keep in mind. People have different reasons for making decisions. All right. Now, the commercial plans are really still the principal source of coverage for a lot of people, specifically those who are employed or retiree coverage. It covers about 170 million Americans, and this continues to grow as the population gets larger, so it's still a very, very important piece. And they administer, like I said, either medical or pharmacy benefits for these patients. Medicaid is, as you guys are probably aware, a public source. It's a combination of federal and state funding for low-income Americans. All right. Currently, about 55 million Americans are enrolled in the different states. What's interesting is under the Affordable Care Act, there's discussion that up to about 12.5 plus or minus million patients may actually go into the Medicaid system. So you're going to have more patients in that piece. And there's a continual struggle because the federal government doesn't want to pay for it necessarily. The states don't want to pay for it. So it's like, we're getting these people in the system, but who's going to pay for it? So it's always a challenge. We then have Medicare, which is government funded as well, specifically for the elderly and disabled. And this is probably the fastest growing sector within the managed care field right now. Basically, there's an expected increase in current enrollees from about 46 million beneficiaries to about 78 million beneficiaries between 2010 and 2030. So a hugely growing segment. And again, think about this. 15 years ago, Medicare Part D didn't exist. So these 78 million patients that we're talking about at 2030 had medical coverage, but not necessarily pharmaceutical coverage. So you can see how things are really, really shifting in the landscape over the last decade or so. All right. And then finally, you have the DoD and the Veterans Administration, which is about another 30 million folks covered under those plans, but again, through the government. So that gives you kind of the overall landscape. All right. So go ahead, sorry.
What's the difference between medical coverage versus pharmaceutical coverage?
The difference between medical coverage and pharmaceutical coverage, specifically in the Medicare group, or?
I have no idea because I'm not from the US, but either way, in general or?
Well, so typically medical coverage revolves around hospital visits, physician visits, anything that's not specifically a pharmaceutical product. All right. And prior to the early 2000s, patients who had Medicare coverage, unless they bought supplemental insurance, didn't have pharmaceutical coverage. Okay. Commercial plans typically did, but not specifically for Medicare. All right. So overall, today's environment of the landscape. In the US, 2011, healthcare costs reached about $2.7 trillion. This is a big, big number and why everybody's talking about it. But the interesting thing is you don't hear people talking necessarily as much about healthcare as a whole as you do about prescription drug coverage. And I think a big reason for that is because patients are more apt to pay a larger portion of their prescription drug coverage bill than they are of their overall medical coverage bill. So that's why there's a lot of dialogue right now. Prescription drug spending was actually not that high when you consider the overall landscape at only about $263 billion. And that stayed relatively flat year over year. It was only about a 2.9% growth, whereas the overall healthcare spending grew at about 4% per year, okay, year over year. So there weren't a whole lot of notable changes with the Affordable Care Act coming in line. We'll see a lot more of that in 2014. But in 2013, what we did see that affected the pharmaceutical industry specifically were three things. First one, there was a provision in the plan that allowed for dependents to stay on or to move into their parents' coverage up to the age of about 26. Okay, or up to the age of 26. So that actually moved about 2.7 million people into having coverage where they didn't necessarily have it before. It's not to say all of them didn't have it, but it certainly moved more people into the whole healthcare landscape that before was there. It extended and increased the rebates that pharmaceutical manufacturers had to pay for specific Medicaid plans. And it also increased and changed the whole dynamic of the Medicare Part D structure and the amount that pharmaceutical industry had to pay into what was called the donut hole. Now, are you guys familiar with Medicare Part D in the donut hole at all? Okay, no. So it's kind of complicated. I try to walk you through it because everything with the government's complicated, right? Basically, for somebody who has Medicare coverage, Part D, which is their prescription drug coverage, they're responsible, the beneficiary is responsible for about, and I'm going to get these figures a little bit messed up, but about the first $325. Okay, they pay the entire amount. That's considered their deductible. It then goes into a second tier. And for the next like $2,600, give or take, of their drug coverage, they're responsible for 75% of it. The plan pays for 25% of it. Okay? It then goes into what's called the donut hole for about another $6,000 or so. In that donut hole, for brand name drugs, pharmaceutical manufacturers need to provide a 50% discount on the branded drugs. And then for the rest of that 50%, the beneficiary pays 47.5% of the cost, and the plan pays 2.5%. Okay, so the interesting dynamic here is that, and the generics, by the way, is that same 75-25 split where the patient actually pays for 75%. So the interesting dynamic when you get to the donut hole is that while you may want to start a patient off on generics because they're fronting a lot of the burden, right, of the cost of the drug, when you get to the donut hole, it may actually be cheaper for them to be on a brand name medication because of the rebates pharmaceutical manufacturers are paying. So it's actually impacting patient or physician prescribing in a lot of cases because the question becomes, do you start a patient on a generic or do you start them on a brand knowing that when they hit this donut hole, the costs are going to be less for them? It's an interesting conundrum, but it's just something as all these things are rolling out that we're having to face.